All right. Welcome everyone. I'm Anita Skandaraja and I'd like to welcome you to this fortnight's Grand Rounds for Breast Cancer. First of all, I'd like to acknowledge the traditional custodians of the land on which myself and today's presenter and the audience are located. I would also like to pay respect to the elders both past and present and extend that respect to other Indigenous Australians online today. Before we kick off today's program, there are a few housekeeping notes. The VCCC have some interesting breast webinars coming up and you can register via the VCCC website, and you can also browse other VCCC events. Please note that today's event will be recorded and it will be available on the VCCC Open Learning page, where you can also view last year's program. Now, in terms of asking a question, if you have any questions for today's presenter, you can do this via the Zoom Q&A function. You can also use the chat function, and please submit your questions throughout the presentation and we'll aim to cover your questions at the end of the session. Now, I have great pleasure in introducing Professor Christobel Saunders, an internationally recognised surgeon who's one of Australia's research-oriented cancer surgeons. She has substantially contributed to many clinical aspects of breast cancer research, including clinical trials of new treatments, psychosocial, translational and health services research, and is active in several areas of surgical oncology cancer research, with a particular emphasis on breast cancer. Today, she'll present her exciting new work, which seeks to improve the outcomes of breast tumour surgery. The new technology and methods aim to localise small impalpable tumours to distinguish any tumour tissue, even microscopic amounts. And this is to ensure that we can achieve the best result. So once again, we'll take questions at the end and I'll hand over to Christobel.
Thank you very much, Anita, and thank you for all who've invited me, in particular Bruce Mann. And it's fantastic to be here with you all. It's just such a shame that we can't be there in person, but I guess this is the brave new world, but hopefully soon we will be there in person. Now, I've been tasked today to talk about surgical research in breast cancer. So I've given it the title, Removing All the Tumour in One Operation. Is that so hard? I mean, surely us surgeons can just cut a tumour out and it's a fairly simple process. So I want to talk to you a little bit more about, if I can move my slides on, here we are, a little bit more about some of the issues that we have around that particular task. But first, just to start by talking about cancer surgery and surgical research. Surgery, as you're probably aware, is usually the first, but often the only treatment for many cancers, and for many cancers can be curative. And so it's really vital that we improve the accuracy and the efficacy of our cancer surgery. But interestingly, if you look at clinical trials, about 83% of clinical trials are drug trials. So we actually do relatively little surgical research. And yet for women with breast cancer, and indeed for their treating surgeons, the goal of surgery is really to get the best possible outcome. And that means removing all of the tumour in one operation, making sure they have the best oncological and cosmetic results. However, around 1 in 5 women, unfortunately, will need a repeat surgery, will need a re-excision, because they have very clear, very close margins on the ventral pathology. And that, of course, that re-excision, as we'll talk about later, can affect their outcomes in many different ways. So what I want to talk to you today about is a little body of research that we've been working on for a number of years, trying to improve these statistics, trying to really look at better methods that we can localise impalpable tumours and therefore remove them more effectively. And indeed a technology that we're trialling to try to see whether we leave any tumour left in the cavity, which would again, hopefully improve these re-excision statistics. So again, our aim really is to remove all the tumour in one operation and with the best possible results. And the picture I put up there on the slide for you is now a typical cancer surgery team. And you can see that all the surgeons there just happen to be women, apart from the chap looking on who's worn a pink hat just to show a bit of solidarity with us, I think. So I'm having a little bit of trouble just moving my slides on. Here we are. So as I'm sure this audience absolutely know very well, breast cancer is a really common disease. In fact, this year there'll be around 2 million women diagnosed worldwide. And again, as I'm sure you well know, there are 2 main surgical options for women diagnosed with breast cancer, mastectomy or breast conserving surgery. And that can be done often with new or oncoplastic techniques, which I'm not going to discuss today. In most modern practices, around 60 to 70% of patients will be eligible to have breast conserving surgery. And indeed, that's probably increasing. We know that with the large numbers coming through our breast screening programs, up to 50% of these cancers are impalpable, and virtually all of ductal carcinoma in situ is impalpable. So we need to localize cancers before them to find those tumors. But the other thing that I really want you to have a think about that we'll come on to as we go through this talk is that when we actually excise a tumor, the only way we can really know that it's completely out is when we get the final pathology a week or so later. And even then, do we really know it's all out if the margins are close? And that's what we're going to be addressing. So I, as a surgeon, need to know a few things to optimize my breast cancer surgery. And this is what I would ask as a researcher in the space of breast cancer surgical research to really try and answer. We need to know the exact extent of the lesion before surgery. I'm not going to talk about this a lot today, but we certainly have a lot of interest in this country in techniques such as MRI, contrast enhanced spectral mammography, and there's increasing experience in these techniques, particularly in Melbourne and in Perth, to try to know the exact extent of the lesion before surgery. We also need to have a surefire and quick technique to localize those impalpable lesions so we know exactly where to go when we do the surgery and we can remove exactly the right area. We need to be able to detect exactly how much tissue to remove at surgery, but perhaps just as crucial, how much to leave behind. And we need to do all of that in one operation. We need to get the best possible outcomes for the patient, cosmetic as well as oncological. And with increasing numbers of patients now having neoadjuvant chemotherapy, and certainly in our practice, that's around 20% of patients, it makes all of the above much harder. Patients having a good response to chemotherapy is obviously a great thing, but it makes surgery and localizing those lesions a lot more difficult. So what happens if surgical margins aren't clear? Well, as I said at the beginning, generally during surgery, we're not entirely sure. We have a few mechanisms that we'll talk about in a while about how we can try to look at margins, but generally margins are reported by the pathologist sometime after surgery. And if those margins are close or involved, that means the patient needs repeat surgery. And indeed, if you look throughout the literature, throughout the world, that rate of repeat surgery is around 20 to 30% for breast conserving surgery. So up to a third of women need to come back for a second or sometimes a third operation. However, most of the time when we do that second or third operation, there's no residual cancer left in the cavity, or at least in the area that we remove. And having further surgery has a lot of costs. It has a lot of downsides. Obviously, it's more expensive. It's more expensive to the system of needing more operating time, but it's also more expensive to the patient often. It results in longer wait lists because we have more surgeries to do. It often results in worse cosmesis. We know that there's more side effects such as infections, seromas, volume loss, other problems for the patients. And in fact, we know that around 50% of patients who do come back for a re-excision will actually have a mastectomy, whether they need it or not. Often, if a patient we're worried about their margins, they'll have a higher dose of radiotherapy to that area, so a boost of radiotherapy, which again can result in worse outcomes in terms of cosmesis. It's possible that we may miss lesions. You can see on the little diagram on the right there how it's quite easy to miss a lesion that's right on the edge. And that could potentially lead, of course, to increased local recurrence rates or possibly worse survival if we're leaving tumour behind. Now, the argument that I'm sure all of you will bring to me is margins don't really matter nowadays. And in fact, the American group, the Society of Surgical Oncology and ASCO developed some guidelines back in 2014, led by Monica Morrow, a surgeon in New York, suggesting that for invasive tumours, no tumour on ink for invasive cancer and around 1 millimetre for ductal carcinoma in situ is absolutely fine for a margin. And there's been a lot of research around the world that suggested that if we follow those guidelines, then there'll be a decreased re-excision rate and no harm will come to the patients. We were very interested to see whether those guidelines were applicable in Australia. And what I'm going to talk to you about now is actually some unpublished data, which we're hoping to finalise and publish soon. But we looked at population data from all of WA for the 4 years before and after these guidelines were published. And I have to tell you, there has been absolutely no decrease in the rate, no change in the rate of re-excision before or after these guidelines were published. In fact, it is falling. It's falling by about 0.8% a year, but that rate is exactly the same before and after the guidelines were published. And actually for all groups of patients as well. So although our rate has decreased to around 22% re-excision rate from 26% in 2012, that rate of fall hasn't changed. And it's also confirmed the fact that unfortunately half the patients who come back for a re-excision end up having a mastectomy. So whether these guidelines are helpful or not, I'm not entirely sure. First, I want to talk, however, about optimizing surgery for breast cancer. I've already explained that around 50% of screen-detected lesions are impalpable. And we know that the most common way that we localize these around the country and indeed around the world is using something called a hook wire, a very fine wire that's put in under either ultrasound or stereotactic mammogram guidance into the lesion. You can put a few wires in, and surgery, you have an x-ray to see where that's gone, and you try to remove the lesion by following the wire down and cutting it out. About 90% of surgeons, indeed, in Australia and New Zealand use this localization method, and it's been used for many, many years. But it is a bit difficult. There are certainly technical challenges of wire insertion, and if you think about it, the patient usually has the wire inserted, certainly if it's stereotactically inserted, with them lying prone or upright, and then they come to the operating table and they're in a completely different position. The wire, especially if it's a very long wire and a large breast concertina, it can be very hard for that patient positioning to know exactly where it is. The wire can move, we can get complications with it. And really, when we use wires, we're absolutely harnessing together the radiological procedure of the wire insertion with the surgery. So generally it has to be done on the same day. It's very difficult to send a patient home for 1 or 2 or 3 days with a wire sticking out of their breast. It is uncomfortable and nasty for patients. So we decided a few years ago to look to see whether we could do something better than wire localization. We looked at other methods that were being used. A few sites use carbon tracking. I've always found that quite difficult, putting a carbon track into where the lesion is for many reasons, but a few centres do use it. I know in Sydney, Andrew Spillane's group are using injection of technetium label antimony called the roll procedure, we tried that and we found it quite difficult. You're injecting just some liquid into the breast, which spread everywhere, and I personally found that very difficult to then localise the lesion. Intraoperative ultrasound can be useful, but many lesions, particularly DCIS, can't be seen on an ultrasound. There's some newer magnetic techniques which are looking quite promising, but it does mean you need special instruments in the operating theatre, non-ferrous instruments. And then radio frequency devices are just beginning to come on board, and I'm very much looking forward to seeing those, actually, the Savvy Scout and others, but at the moment they remain quite expensive. But one other technique we came across used in a few places in the world was using a very small radioactive iodine seed, and we've called this the Rollis technique. These are the little seeds, very similar, in fact the same as the ones that are used in prostate brachytherapy, but with considerably less radiation. So they're almost like the brachytherapy seeds when the radiation is beginning to run out. So they do contain radiation. And so that was the first thing we asked about. Well, if we're going to put radioactivity into patients with breast lesions, is it safe? Well, the radioactivity that's emitted by the radioactive iodine seeds is very, very low. It does have a long half-life, however. But we looked at the radiation exposure to everybody who could come in contact with these seeds, the patient, the radiologist, the surgeon, the pathologist, ancillary staff, and the radiation exposure is very minimal. And of course, remember, we're using these largely for breast cancers where the patient's going to have radiotherapy afterwards. And in fact, if putting it into perspective, you'd actually have to sit next to one of these seeds 2.5 hours a day, 5 days a week for an entire year to get the same as the background radiation. So we think they're very safe. Actually, that long half-life can be a major advantage, as we'll come on to later, because these seeds can be put in many days before surgery. So you're immediately avoiding that problem of coupling surgery and radiology. You're uncoupling the two, and you're also uncoupling the hospitals. The seeds can be put in at one hospital and the patient come elsewhere for their surgery. In fact, we're hoping that we may be able to use these even before neoadjuvant chemotherapy. However, using an enclosed radioactive device does come with a lot of legislative protocols that need to be developed and then followed. And they'll be different from state to state, but you certainly need to have appropriate licensing to use an enclosed radiation source. You need to have training, and you need to have a handling protocol for that seed, so you follow it all the way from where it's been inserted to after it's been removed by the pathologist. And once they're developed, it's pretty straightforward. We had a look at the literature to see how useful using these radioactive seeds were, and we found a little bit of work in the literature. We found 1 RCT and 4 cohort studies, but the quality of evidence was relatively mixed and small. So of course, what do you do when you don't know what the evidence is like? You embark on your own. So we embarked on our own trial a number of years ago. We call it the Rollis trial. We finished recruiting to that trial last year, and we're just publishing the evidence from it. And our hypothesis was that the use of these low activity iodine-125 seeds for localizing impalpable cancers would lead to a reduced incidence of positive margins and a reduction in the re-excision rate. And we powered the study appropriately. So we had around 650 participants from all around the country and New Zealand entering patients into this study. We also looked at some other outcomes because we'd hoped that being able to use these little seeds would mean we could take out less tissue and therefore get better cosmesis, which we measured on a whole load of different scales. We looked at complications. We looked at patient and clinician satisfaction. Were these acceptable to patients and were they easier to use for surgeons and radiologists? And of course, if you want to get anything used in practice, you have to look at the cost effectiveness analysis. You have to do your health economics. Otherwise, there is no way that hospitals and health authorities are going to use a different procedure. So I'm just going to summarize very briefly the results because, as I say, it's been accepted for publication but not yet published. But suffice to, we have had a number of other papers published. Suffice to say that patient satisfaction was much better. Patients like these little seeds. They're easier to put in. You can put them in days before. There's less discomfort than having a wire. Surgeons and radiologists generally find them easier as well. Cosmesis, certainly in the first year, was a little bit better for the Rollis seeds, probably because we were taking out less tissue. There was a non-significant improved rate of clear margins, but our other primary endpoint, lower re-excision rates, we met. So they were statistically and clinically significantly lower re-excision rates with Rollis, which we were very pleased to find. Like everything, there can be complications. Probably our most serious was a seed loss, and that, you know, you have to look through all of the theatre gear. You have to get a gamma probe out and find them. And you need to be careful because patients often now have lots of bits of metal in their breast, so you need to be wary of which bit of metal you're heading for. The other useful thing we found about these is that you could bracket large lesions with them like you can with a hook wire, as long as the lesion is at least 2 centimetres in size. And as I said originally, we're hoping to be able to use these with neoadjuvant chemotherapy, both to put them in the tumour right at the beginning before as a marker, and so we can find the tumour after neoadjuvant chemotherapy, even with a fantastic clinical and radiological response, and perhaps even use them into any involved lymph nodes, so targeted axillary dissection can be done at the end. So that's something that's currently under investigation. So to summarize, the advantage of this technique, I think, is that it does lead to better outcomes, lower re-excision rate, more comfortable and convenient for the patient, equal cosmesis, and in fact, we're just about to show that it's at least as economical. Certainly surgeons and radiologists preferred this, but it's really important. I think one thing I've learned is what a big collaboration this was in terms of doing research from people who you may not normally collaborate with in clinical trials, the radiologists, the physicists, health economics, etc. And now we're trying to translate this into practice so it can be funded and used throughout this country. So the second question I wanted to really address was, out of those questions that I put at the beginning in optimizing surgery, was how can we actually work out exactly how much tissue to remove when we're doing an operation and how much to leave behind? I mentioned to you that the re-excision rate currently in most practices around the world is anywhere up to 20%. And many of these patients end up having a mastectomy. And we've mentioned that there are many complications and worse outcomes when a patient has to go back for a second surgery, not least the expense. We've worked out that in the United States, the cost of re-excision surgery, both in hospital and out-of-pocket costs, probably comes to around $1 billion a year. That means there's a lot of pressure for us to find better ways of doing this. And the current tools that allow a surgeon to intraoperatively assess residual tumour are not that effective or efficient. Why is that? Well, what we currently use is we use our eyes to look at the imaging, and we often do intraoperative imaging. We use our fingers to have a feel what we remove. But the problem is that not all tumours are the same. And I'm sure you're aware that the margins that we see on radiology often correspond then to the pathology margins can be very different. So it's fairly easy to find a well-circumcised medullary cancer in a fatty breast. But when the tumour is very spiculated with ill-defined margins, it can be difficult to detect where the margin that you're removing is. And you can see that in the little illustration in the middle there, that residual disease is quite easy to leave behind. We know that for some subtypes of cancer, that's much more common. So lobular cancers notoriously are the ones that are most difficult to know where the edges are. Extensive DCIS, particularly if it's not calcified, can be difficult. And I mentioned at the beginning how everything is more difficult after neoadjuvant chemotherapy, which often doesn't just shrink the tumour down, but kills the tumour in lots of little bits. So you're left with stromal tissue infiltrated with small microscopic areas of tumour. I think the aha moment for us came when we thought about removing the tumour, and what we do now is we assess the lump that we've removed to try and see if all the tumour's there, and that's what the pathologists do. They look at the margins, which is the lump that's been removed. But what really matters is there any tumour left behind? And we know when we go back to Re-Excision, a lot of the time there is no apparent tumour left behind. So really what we wanted to do was find something that would assess if there was residual tumour in the cavity, not if the margins were close. So actually, I don't care about margins either. What I do care about is there tumour left behind in the cavity after we've done breast conserving surgery. Looking at the existing intraoperative ways of doing that, they are either not that accurate or they are pretty expensive. I know that a few places will consider intraoperative histology. I think that was done for many years in Milan. Having a pathologist in theatres, I don't know if we've got any pathologists on the call, but I don't think that Professor Fox would be that happy if he was called to every operation that was done at the Peter Mac. Intraoperative X-ray is widely used. We all use it, we all rely on it, we all are very happy when we X-ray the specimen and hope that we can see nice clear margins, but we also know that it's not very sensitive. And in fact, nearly half the time we get it wrong on the intraoperative X-ray. Equally, intraoperative ultrasound is not that accurate, but also many tumours, you can't see those difficult things like DCIS on ultrasound. There are a few new tools, such as the margin probe, intraoperative radiofrequency spectroscopy. Again, its accuracy is not that great. We looked at some of the devices in development, and I'm going to come back to the one at the top, which is our device, the OncoRes device. So there are a number of other devices in development. Many of them are not looking at the cavity, they're just looking at that removed tumour. They use a whole load of different types of technology to look to see whether there's residual tumour. Most of them have not shown yet good tumour identification, although clearly for a few, we're like Lumicell, we're waiting for that. The problem with Lumicell is you actually have to inject an agent which is a luminescent agent into the patient, which has its own complications, clearly. So we, some years ago, landed on the idea of using some technology called optical coherence elastography. Now, optical coherence tomography is really just using light to look at the different tissues and the penetration and bounce back of light from different tissues. So it's a little bit like using ultrasound, which uses sound waves bouncing back from tissues. This is using light waves. And the advantage, of course, of using light waves is that you can get much, much better resolution than you can with sound waves. And so the resolution is right down to 5 to 10 micrometers. The problem with using light, as I'm sure you're all aware, is it doesn't penetrate tissues very well. It only goes down to 1 or 2 millimeters in depth. But of course, if we're just looking at margins or at residual tumours, we probably only care about the first 2 millimeters or so of tissue that we're looking at. We then had the idea of adding to the optical coherence tomography something called elastography. And elastography is really looking at the mechanical loading and the change in the image parameters with different mechanical loads. So this you'll be well aware of using elastography with ultrasound, and it's used with MRI as well. So we're using it with optical coherence tomography. And this just explains to you in a sort of very simple diagram what we mean by that. So we put a mechanical load onto the tissue. We image it pre and post deformation to look at the difference in the tissue after the loading has been done. And then using a little bit of fancy maths, we can look at the properties of the mechanical properties of the tissue after loading, and then form an image called an elastogram with that information, with that data that comes back. And we can also do this in a quantitative way. So rather than just having one load on that, we can have a range of different loads. So you can get, if you like, a heat map of tissues. And we first did this on excised cancers after a mastectomy had been done. And this was some really exciting data that we first realized that we could really see using this quantitative microelastography or optical coherence elastography. We could very well distinguish between tumor tissue, adipose tissue, and stromal tissue, that they all had different properties, optical properties, when pressure was put upon them. Essentially, tumor tissue is more stiff. So we did some feasibility studies on mastectomy specimens, and how we did those was very carefully align the imaging that we were doing with optical coherence tomography and elastography with exactly the same image on histology on the actual cut slide. So this was done with a lot of help from our local pathologists. I've got some Q&As there. I'm not sure if these are things I should be
We might have been at the end, perhaps.
Okay, well, do those at the end. Okay, sorry, I will shut up, Anita, and carry on. So when we added elasticity on, you can see this heat map is really very, very noticeable. And this excited us because we could see that we could clearly differentiate tumour from normal breast tissue. So the next thing that we needed to do after that was an accuracy study. And we did this as a benchtop study. This was published in Cancer Research recently. And we got a load of readers who were either surgeons, pathologists, various other people who looked at a training set. They learned how to do this a little bit like if you learned how to look at an ultrasound, and then they matched with a blinded study whether they guessed whether it was cancer or not. We used 154 different areas to show them. This came out of 71 different cancer specimens. But we used different areas within the specimens, and out of that 24 had cancer and 130 didn't. And this was a completely blinded study. So those of us who were looking at these images had no idea. And this is what we learned to see. And we learned to do this within half an hour. It wasn't a difficult task to learn. So basically we could see quite clearly with both the OCT image, but even more with the elasticity on top. The blue images is essentially benign tissue, benign ducts, and fatty tissue, adipose is very clear to see. And then this tumour tissue, which came up as red, it came up as dense, and that persisted through the tissue. And see, it's not only ordinary cancers that we could see, ductal cancers, but we had some lobular cancers in these images showing you a mucinous cancer, which showed very similar properties of the tumour, and even DCIS, ductal carcinoma in situ, this was high-grade DCIS, also showed these very different tissue properties that we could see on OCT images. These images, if you have a look here, this is only 1 millimetre in size, these images that we're seeing. So these are the results of our accuracy study that we published, and really have a look at just what's circled in red at the bottom. So the OCT only wasn't so accurate, but when we added the elastography on, or this QME as we call it, we really got some very good sensitivity and specificity. I think enough that you would clinically be fairly confident that you could tell if that was tumour or benign tissue. So on the back of that, we thought, well, what we need to do now is develop a probe that we can actually use in the operating theatre to use this technology when we've removed a tumour to see if there's any left behind. So this was the probe that the very first generation of probe that we developed and we tested in the lab. And indeed the handheld probe, we could see exactly the same thing. We could clearly, you can see the image at the bottom, you can clearly see the red areas of invasive ductal carcinoma that match almost exactly to the histology. We then took it into the operating theatre, and we've now used 22 patients at Fiona Stanley Hospital in the operating theatre in the cavity. So we removed the tumour, we put the probe in, we have a little look to see what the different margins. This is a blinded study at the moment, so it's not affecting what I'm doing as a surgeon, but we're then co-registering the pathology. We remove a small margin where we've taken the image and co-register it with the pathology. We do have to use these, we've had to go through a lot of hospital protocols to make sure that this is a sterilised probe, and we use a sheath as well. At the moment, we're busily developing a new, easier to use probe, but it's being used by multiple surgeons and is relatively easy to use. One of the areas we thought we'd try to develop a little bit better is another optical property called attenuation, which really will give us a much better map of areas that might be tumour or might not be, or might be adipose tissue. This uses some highly complicated maths, which I have to say I can't explain to you, but you're welcome to talk to our physicists if you're particularly interested. But using these two attenuation coefficients, we're able to probably get a more accurate picture for the probes that we're using. So we're developing this a lot more at the moment, and we have a whole lab working on this. And so these are some of the attenuation images that you can see here, again, clearly showing the difference between tumour and benign tissue. We thought it would be useful to also develop, along with this at the same time, a simple camera-based optical palpation, something that would be cheap and cheerful, if you like. And this is based just on using a digital camera, but similar sort of technology. And again, using stress, but using just, rather than using an OCT machine, just using a digital camera. And this certainly isn't as sensitive or specific, and it's under development at the moment, but it may be a sort of a low cost option that may be useful in some circumstances. And you can see here, these are some of the images at the moment we have for the digital camera, nothing like as pretty as the others, but they may give you a gross idea of where tumour lies and where it doesn't. So finally, we've now had to look at commercialization of this technology, and that's been an interesting journey in itself, understanding how to commercialize new technology. We have a company called OncoRes Medical, funding from a number of government and other sources, philanthropic sources. We've been able to develop this. We certainly have a board, including people from Silicon Valley in the United States, to show us how to develop this kind of technology. We're looking at how this will fit into the surgical workflow. So if this is how you imagine we do an operation, you know, we localize it, we excise it, we have a look at the specimen, we look at the cavity, we may take a shaving, remove the sentinel node. You know, if we're reasonably quick, that might take us 25 minutes to do that. Me as a surgeon says, I don't want to spend a lot more time using an instrument that will look at the cavity. So we're working to add perhaps 2 minutes on using our OncoRes probe to find whether we've got any residual tumour, and we're getting very close to that at the moment. So we hope to be able to develop something surgically useful. And this is where we're at the moment. So we've done our first in-human studies. Our clinical validation is going on at the moment with a device that we have made in our research laboratory, but we're now developing a commercial product. We have a commercial laboratory, and we have help from various commercial companies in the United States. And by next year, we're hoping to set off with an initial efficacy study around Australia. And I'm very much hope that many of you guys might be interested in joining in on this. So let me know if you're interested. We'd love to have you on board. And then eventually, unfortunately, like all of these things, you have to go to the United States if you really want to play in the big time. So eventually, the large pivotal study will be done in the United States. We hope regulatory approval, we already have provisional regulatory approval, but eventually regulatory approval may come in the next 3 to 5 years. So I've really talked to you about a few things today. I've talked to you about optimizing surgery for breast cancer, knowing the extent of lesion. I haven't talked about the research we've been doing in MRI, but we're very interested in that. But I hope I've shown you that you can develop a better, quick technique to localize lesions for surgery. It might not be the final answer, but a randomized controlled trial has shown us that there is a better way than we're using. I'd like to show you that we are in the process anyway of developing a technique that might show us exactly how much tissue to remove at surgery and how much to leave behind, and therefore to reduce the need for re-excisions and be able to do a patient surgery in one operation. And obviously we then need to show the outcome of any large trial will be to get the best outcomes for the patient, both oncological, cosmetic and economic outcomes for the patient. And what will be really hard in this new era of having more and more patients having neoadjuvant chemotherapy is to do that after neoadjuvant chemotherapy. I'd like to thank you all for listening, and I'd like to thank many collaborators. I couldn't list everybody, so I've just named 2 really. Dr. Donna Taylor is a radiologist I work with who's done most of the work on the ROLIS trial, and Dr. Brendan Kennedy is a biomechanics engineer who's done much of the work on the optical probe. We've also had lots of funders and, of course, many, many patients who've been contributing to this work. So thanks very much, Anita.
Thank you very much, Christobel. Thank you for a lovely summary of the problem at hand, and also a really good example of collaborating beyond, say, surgery, using physicists, biomechanics, radiology. You know, it's a cast of thousands to get to where you are, and obviously we don't have all the answers. I have several questions, but we'll perhaps address the ones that are in the chat first. A question from Stephen Statter, and that's just the difference in the metastatic patterns of patients with residual tumour versus those that are removed at the first operation, if any.
Well, I guess it depends on the biology of the tumour ultimately, doesn't it, the metastatic pattern? So I don't know that I can answer that question very easily. We know that the tumours that we're more likely to leave behind are lobular cancers and patients with extensive DCIS along with their tumours. We know that even if we leave behind DCIS, unfortunately, 50% of that recurrent DCIS will come back as invasive disease, and often high-grade invasive disease. And only this week I've actually seen 2 patients who initially only had DCIS, had mastectomies. One has come back with widespread metastatic disease and the other has come back with invasive disease, which is lymph node positive, only a few years after their mastectomies and reconstruction. So there is no doubt that leaving tumour behind, presumably there must have been a bit of DCIS left behind, leaving tumour behind can result not only in local recurrence, but in metastatic disease and indeed in patient death. So I think surgery remains important, despite the fact that we often, we hear so much about new drugs. And as I say, 87% of all clinical trials are drug trials, and they're fantastic. And there's some really exciting new drugs. But I think it still is really important to remember that surgery and or radiotherapy still cure most women with cancer.
So a question from Stephen Fox about how the system managed invasive lobular carcinoma.
How our onco
managed.
Yeah, thank you, Stephen. I thought you might be there, which is why I had to mention you and say that you didn't want to come to theatres for every case. Look, that's my most important question to the engineers, because like all of these things, it's always easy to do something on an easy cancer, isn't it? It's like any radiological technique. You can always see the easy cancers. Well, they're not the ones you're interested in. It's can you actually do the more difficult things? So we made sure that when we did the initial reader study, we did include all cancers, but it was a small study. We didn't have hundreds of cancers. It performed exactly the same on lobular, we had a couple of post-neoadjuvants, on DCIS, so we had some two mucinous cancers as well, and it performed the same on all of them, but it is early days yet. So I can't promise you that it will perform as well on lobular cancers, but the early data is, and I think when we do start looking at the larger clinical trial, we'd like to enrich the clinical trial with the more difficult cancers, because there's no point in having an instrument that could see something that, blind Freddy could see. We need something that can detect the things that are difficult to us. But for me, that's been the real joy of this research collaboration, because we can ask those difficult clinical questions, both, us as surgeons and the pathologists that we've worked with on this study. And then it's up to the engineers to try to answer those. Yeah.
And a second question from Stephen about whether you've used it in pathology cut-up, and particularly after neoadjuvant cases.
Yeah, well, I've been encouraging our company OncoRes to develop a probe that would be used, and we're discussing it last week, Stephen, so they may come to you about this, because I've suggested that it could be a very useful modality as a sort of quick thing for the pathologist to guess where the tumour might be when you're cutting it up. So all of our initial imaging and all of our initial studies were done ex vivo in the pathology lab, in the anatomical pathology lab at Fiona Stanley Hospital immediately after surgery. So we'd have the engineers would be in theatres, they'd collect the specimen, and we started with mastectomy specimens and moved on to wide locals. They took them to the path lab with the pathologist, they were cut up, and then we were looking at the difference between the cancer and the benign tissue. And obviously that performed well, but I think it could be a useful tool for you guys in the path lab to see, especially in a large specimen, say mastectomy specimen, where you're not quite sure where the tumour is, to be able to detect tumour. And as I say, it does seem to be able to detect down to the micrometer level. So, a couple of microns of disease we can see with the probe, as long as the probe's on the right place. And we're looking at different fields of the probe as well. So it can be anywhere from, a few millimeters up to a centimeter to look at the same time. And the whole workflow of those things is being worked through, which is the interesting thing about having a commercial company. You start to think about all of those complicated workflows.
Another question, Christobel, could you possibly discuss whether these new techniques and devices will help detect highly invasive diseases such as inflammatory breast cancer? I think that alludes to the neoadjuvant sphere as well, making it.
Yeah, well, inflammatory breast cancer is such a difficult beast, because we know that although there is a preponderance of, grade 3 disease in inflammatory cancer, inflammatory cancers can be anything. As you know, they can be any grade, they can be lobular, ductal, or otherwise metaplastic cancers. And I guess the pathological signature of an inflammatory cancer is that subdermal lymphatic invasion. I don't know, we haven't looked at an inflammatory cancer, so I've never put the probe on the outside of the skin of a lady with inflammatory cancer to see if it can detect that or not.
Through the other site, do you anticipate that your cost analysis of the introduction of the probe will be helped ultimately by making specimen x-rays machines in theatres relatively obsolete? That's from a radiologist.
Oh, well, you know, we love specimen X-ray. I don't know if you do, Anita, but we love the specimen X-ray machines. And, you know, we even did a little study a few years ago, one of our fellows did, to look at, see whether it changed re-excision rates, and it doesn't even slightly, but we think it does. We have this firm belief. We love X-raying the specimen and going, oh, look, the superior margin looks close, we can take a bit more out. And yet it's never really been shown to be helpful.
We've done exactly the same study, Christobel, and unfortunately, despite the evidence, we love it and we still use it and find it very useful practically.
So maybe it's a sort of cultural or behavioural thing that will have to change eventually. I don't know.
Oh, it just feels like it's a bit like bedside ultrasound. It's like an extension of our operation, if you like. Just bringing you back to rollers. Obviously, we need to read the paper in BJS, and we'll wait for that. But practically, with the management of the seed, you've alluded to the fact that we're pretty impatient in theatre. We don't like anything that adds extra time. My exposure to watching the iodine seed management, particularly in pathology, is that we have to find it takes a little bit of time to make sure that's completely out before the case proceeded in other countries. How have you gone with this sort of time addition or
no? We looked at the timing. It was actually a bit quicker than a wire, because you're using the gamma probe, the same probe that you're using, as you know, for a sentinel node biopsy, just on a different setting. And so once you can localize the seed, it's really pretty easy to do. And once you've removed it, you just put the gamma probe on it. You know the seed's in there. You put the gamma probe in the cavity. There's no activity in the cavity. It honestly doesn't make the timing any longer. I think the only concerns we've had with the seeds are with lost seeds, and we've had a few. And that can be sometimes because they're inserted and they're very, very close to the surface, and you cut into the breast and they kind of fall out. And then the other problem that we've had is if you've got lots of different clips, you need to be very wary of what all your clips look like, because they're all little metal things that look bloody similar. But of course, clips aren't radioactive. That's a good thing. So you can tell what is. But using the radioactive probe, it means that you can very easily find. And if you do lose one, you can, you know, look in all of the towels and everything around the patient to try and find it with the radioactive seed. We did once a few months ago have to bring all of the laundry back from laundry placed theatres to look for a seed.
The reason I asked is that MD Anderson, part of the regulatory process is that you had to identify the seed. So pathology had to cut up whilst the patient was asleep and identified and extracted and documented.
No, we don't do that. We have this, as I say, the sheet of paper that goes with the patient all the way, or it can be an electronic record as well that goes with the patient all the way through. So you record that the seed has left theatres in the specimen. Then when it gets to pathology, it's recorded that it's there. So there's a gamma probe in pathology to record that it's there. And then they phone physics, and physics come and put it in its little box and take it back. So it is important for regulations because it is an enclosed source of radiation, and I suppose they think that if we collect enough together we could make a nuclear bomb or something. I'm not quite sure, but I understand that it's important to trace radioactivity. And the other thing is making sure the patients feel very safe with it, you know, especially if they've got it in weeks or months, even sometimes beforehand, or certainly we put in up to 9 days before surgery. You know, and if we say to them, you know, if you've got a baby, for example, maybe you're not going to hold the baby against your breast the whole time, but otherwise it's quite safe to walk around the house, to, you know, kiss your partner, sleep in the same bed as somebody. That's all fine. It is safe.
So I think our experience of the seed is exactly as you described. Particularly, we often use a mag seed, and it's quite good for those superficial lesions where you don't want to use a hook or carbon. But often, as you say, sometimes as you get in the skin, you lose the seeds. You've got to, or the mag seeds. You've actually got to watch it. Have you got any experience, or do you know in the literature how all these localization techniques are matching up cost for cost? I mean, the wires are cheap, but they're actually a pain with the potential for all the extra procedures preoperatively.
Yeah, well, we're at slightly more than the wires, but only literally a few dollars more. So, and it depends. I can't give you an exact figure because everybody does different deals with the company who supplied things. But essentially, we've been preloading our own seeds. We can buy the seeds pretty cheaply, so it literally costs sort of in the order of $10 or so more than a hook wire. But because of scheduling changes, it actually saves money. So our health economic analysis, which has again been accepted but not published yet, by the Curtin group here, they did it. It will work out to be cheaper than a hook wire. I don't think there's been any comparisons between all of the devices yet. At the moment, the magnetic devices are a bit more expensive because of the one-off device that's used and because of the other instruments. And the Savvy Scout, well, I think they're trying, I don't know if Troy's online from Savvy Scout, but they're trying to sell it in Australia at the moment. And I know that they've got special deals for early uptake people. So it will be interesting to see, but the machine itself is, I think, on sale for around $130,000. So, you know, and then there are the disposables. So it's relatively expensive at the moment. And the roller seed uses the gamma probe that we all have anyway for sentinel node biopsy. So it's literally just the disposables that are extra.
And there's a couple of questions actually about mag seed, but have you had an experience with mag seed? It's particularly
I haven't.
Yeah.
So have you, Anita?
Oh yeah, no, so we've been using it, and we've been using it for the same indications you've mentioned about rollers, including the targeted axillary dissections, seeding the clipped node in neoadjuvant chemotherapy, not for the neoadjuvant, because we've had that insertion time limitation of 30 days. I believe Kate's just alluded to the fact that that's been lifted now, but we've only sort of post neoadjuvant, we've use the seed to target the node, and that's been really successful. But as you say, expensive, but certainly much nicer than any kind of wire. And the localizing a clipped node has always been tedious. We've got a lot of experience, obviously, with carbon here, but I think it'll be. There's no doubt the tract means that you do take further breast tissue than you need to. So I think a seed right at the target lesion is incredibly useful.
There are limitations for seed. I just will say if you're going to use them. So, for example, if the tumour's right up in the axillary tail, sitting next to a sentinel node, it can be difficult. And if you want to bracket things that are, put the bracketing wires too close together, bracketing seeds too close together, that's difficult. So there are other, you know, sometimes we use a mixture. You know, occasionally we'll use a seed and a wire.
Yes, very sensible. Just generally, I think the lobular people have alluded to the DCIS with your OCT and elastography. You showed some higher grade DCIS. Any sort of feel for the differentiate, like if it's low grade or intermediate, whether we can see a difference in the cavity?
Not yet. I suspect that you will, though, because it definitely does have different morphology and different tissue properties and stiffness. I guess then the question is, do you care if you're leaving some low-grade DCIS behind? But that's another talk, isn't it, Anita? That's another discussion for another day, whether how much we care about low or low-risk DCIS and what we leave behind. So I think we're probably going more for the things that do matter to remove. And I think removing all of high-grade DCIS, all of lobular cancers, and trying to get some idea after neoadjuvant chemotherapy, which for me is one of the most important areas, because I think we're going to use it more and more. And that's therefore a nice segue into how we then work with the medical oncologists in these clinical trials as well. And the radiologists, really importantly, as well.
Definitely. So I think there are no more questions on my chat or Q&A. So I will bring our session to a close, and thank you again, Christobel, for joining us in the morning in Perth. For those who are still listening, but also have people who wish to access this webinar afterwards, it will be accessible on the VCCC Open Learning page in the coming days, and you can also follow the VCCC on social media if that's floats your boat, particularly with Facebook, Twitter and LinkedIn. So thank you again, Christobel, and I thank the audience for their participation.
Thank you, it's a pleasure. Lovely to see you all. Bye.